treatment or after treatment, and hopefully, give a little bit of education on all the things we can possibly do to help support you guys in your survivorship. So let's get my slides to work here. All right, so we do have in our outpatient physical therapy rehabilitation office altogether, we have physical, occupational, and speech and swallowing therapy. So I know occupational and speech and swallowing are going to be presenting on Friday. I think it might be 11 to 12, but Ginny, I know, has the whole schedule there. And they'll talk a little bit on some other aspects of things that they can do for you on that end. So if you have questions, you can ask me, but more than likely, I'll probably punt most of that to them when they do their presentation. So the first thing I'm going to talk about is probably one that many people think about especially when they think about a lymphedema therapist or physical therapy, and that is how we interact with our breast cancer patients. So I broke this up a little bit. We've changed things over the last year to year and a half to really try to be more proactive in seeing patients even before they have chemotherapy or before they have their surgery, so that we can see them, we can explain, what is lymphedema, why am I at risk for getting it. We can take baseline measurements so we know exactly kind of where you're starting from, and so that if you have any issues either throughout your chemotherapy or post-operatively, that then we are able to kind of take a closer look and say, okay, where were you before and where are you now? Whereas previously, a lot of it was really being referred to us only when we saw problems with having swelling or having signs of lymphedema. And sometimes it can be a little difficult if we don't really know where we started from. So these days, we really go through try to get every patient we can to come in and see us before surgery, before chemo. We do an assessment, as I said, we provide education, and then we bring them back usually about a month after they have their surgery, and then talk a little bit more about their risk factors and how to prevent lymphedema in that case. Or we also then assess them for how are you doing with your range of motion? How are you feeling? Are we having pain? Are you having problems with your scar or anything along those lines? Allows us to really intervene much sooner and hopefully get in there and really help to counteract or be able to prevent maybe some longer term problems that patients have when they're not being seen so post-operatively by a physical therapist. So I think it's been great for patients. I think hopefully they've appreciated it. I find it's been great for us because we're able to really flag patients really early who need our services. And then we generally follow up with these patients now every 3 to 6 months for about up to 3 years, and then yearly for year 4 and 5. So that said, even if you're somebody who had your surgery or had treatment 4 years ago, obviously you can still be having problems. Maybe it's not directly related, but it possibly could still be related to your cancer treatment that you had. And so the things that we do here overall is we obviously do lymphedema education, prevention, and treatment. We improve range of motion and strength if patients are having deficits, and many patients come into us, maybe they have deficits even to start with that we can help them with. We also work a lot on what we call axillary web syndrome or cording, which for patients coming out of surgery, sometimes they feel like a pulling in their arm, or they notice they have these weird kind of bands that go through their armpit area, and when they try to reach, it's painful. That does occur more commonly with lumpectomies. And definitely sometimes with sentinel node biopsies as well, that we do see that a lot more than we used to. The good news is it's pretty easy to treat, and patients usually do really well. And then we also work with soft tissue mobility or any like fascial restriction, tightness through, say, the chest, the arm from surgery. We also can help manage with peripheral neuropathy, which is something which I know a lot of patients come back to us, usually not maybe right away, but even a year or two out, and are still really struggling with some of those issues from their chemotherapy. And even a lot of it sometimes improving posture. A lot of patients, unfortunately, all of us in our everyday, I'm sure, Ginny and Lindsay can speak to this as well. We spend a lot of our day over our computers, or I spend a lot of my day over my patients working on them. And then I'm home and I'm making dinner, and I feel like I spend a lot of day like this. And so, once you've had surgery too, people tend to be a little more rounded even to try to protect, they're not comfortable. And so we find a lot of times that just improving postural awareness too is really huge, and getting them to kind of open that chest back up again. It puts their shoulders in a better place to be able to work functionally. And so that's another thing we do a lot with our patients on that end. So that's kind of my overall breast cancer, some of a lot of the treatment that we do with those patients. Next, we're going to touch on cancer fatigue, and this obviously can affect anyone going through cancer treatment. Sometimes we don't maybe see as many patients who've been diagnosed with lung cancer or pancreatic cancer, but I feel like this is an area we do see those patients because generally maybe they don't have truly a problem with, range of motion, or they may not have had surgery, but they're getting chemotherapy or they're getting radiation. They're fatigued, they, are very weak. And so we look at cancer fatigue kind of on that spectrum of what we can do to help improve your endurance, improve your walking, your ambulation, improve balance, which is a lot of ones. We also see a crossover with some of the peripheral neuropathies from chemotherapy, especially in the feet, that patients really start to struggle with their balance and find they're a little unsteady. They start to have some falls, and they develop a lot of weakness. The cancer treatment takes a lot out of patients, and they're not feeling like their usual self. They're, tired more often. They tend to maybe be sitting more, taking more naps just to try to, get through their days. And a lot of times they become a little bit weaker, both in their lower and upper extremities. And this is something we can help them to try to either maintain what they've got, but also start to build back to where they were. The next one I'd like to talk about is head and neck cancer. We see more of this coming out of downtown at University of Maryland Medical Center, but we do have a little bit here as well. And a lot of what we do see is a lot of times the treatment for the lymphedema, the swelling that can happen after both surgery or sometimes just with radiation to those areas. But patients also present sometimes with some restriction with cervical range of motion. They're getting back to driving, but they can't, turn their head all the way. Sometimes with some of the surgeries, there is the surgery cuts one of the nerves where they have some lack of range of motion with their arms. Then they can have pain both from radiation, sometimes a lot of it more internally with their eating or swallowing, which I know that speech and swallowing will be talking more about this on Friday. And also just strengthening again. It takes a lot out of them as well, and so some strengthening, and also sometimes some vestibular as well. A lot of times, with some of their treatment, they can also have some issues with, especially, we talk about cancers. I say head and neck, I think more this than that I see, but we've also had patients who've had some brain tumors, brain cancers that then have developed some vestibular issues because of some of the treatment through there too. And one of my other lymphedema therapists is also trained in vestibular rehab and some visual ocular motor, and does a lot of that with patients and has some really good success as well. And then lastly, kind of tackling a little more of a wide spectrum, is some of our melanoma, which I've actually seen in upper extremity as well, but we definitely have had a few more that we've seen more for lower extremity issues, gynecologic and genitourinary. So people do present then obviously with some lymphedema in the lower extremities. And lymphedema can occur anywhere where you have surgery or having radiation treatments. A lot of times we see patients to help them, again, improve lower extremity strength, improve range of motion, improve their balance, ambulation, gait, endurance, and another big one again is with the peripheral neuropathy as well. So I will touch on that briefly because I know it's sometimes a big question people are having. Well, what can you really do for peripheral neuropathy? Here we definitely can teach you. There's certain nerve glides that we can do for patients. We can work on strengthening a range of motion. Sometimes a lot of patients have a decreased flexibility, which by improving that, you can see some changes in the peripheral neuropathy. Education just on skincare, proper footwear. Also, just lost my train of thought there. Avoiding real temperature extremes, so not anything, no ice, not anything too hot. Sometimes those can actually make the peripheral neuropathies worse. We do a little bit of some massage to also help with increasing blood volume and blood flow, and also can help with some of that as well. So generally that's a big question I know patients have with, wondering what can you really do once, the peripheral neuropathy sets in. That one's probably one of the little harder ones to manage, but there are a lot of things we can do to at least improve the peripheral neuropathy, if not get it to almost fully be able to go away. So at this time, I'd really like to turn it over to you guys that are sitting here with me and get your questions and, thoughts or things you want to kind of learn a little bit more in depth about.
Great, Christine, thank you. Yeah, please, any questions that you have that brought you to see this event? We're getting a chat.
I'll go ahead and ask a question on behalf of the patients that I speak with. A lot of them want to know kind of like the process of not only getting an appointment with you, but kind of how the treatment process looks like, how are these treatments really implemented? Is there any pain? That kind of thing. So if you could provide any insight on that, that would be great.
So they're done a little bit differently depending on what the patient's being sent for. So when we kind of go back to that breast cancer protocol, all patients that are presented at our breast tumor board, breast conference, we call it, all patients that are appropriate, which is pretty much 95% of them, get immediately, Susan, who works with Dr. Rogers, sends a referral up to our office, and then we schedule the patient to come in as soon as possible. Sometimes we have to rearrange just to get them in before they have their surgeries. So that's kind of how that process flows. If you're a patient who is not a new diagnosis, though, then usually I would say you can call us directly, but generally the best way to do that would be go through, call Susan, call Dr. Rogers' office, say, hey, I'm having some problems. I think I need some physical therapy, could really help me. They're usually fantastic. If you call my office directly, we can absolutely reach out to them and get the referral. It's just sometimes easier if you just call them and they send it up to us, and then my administrators will call you and schedule you as soon as we can get you in. And then, generally, this is true of mostly anyone who needs to come for therapy. If you're working with any of your providers, whether it's your medical oncologist, your radiation oncologist, honestly, even your primary doctor can send you. Ginny sends patients over if you work with her or see her. So anyone in the cancer center who, nurse practitioner, PA, or your physicians can send the referral for physical therapy or occupational therapy or speech therapy. And then we call to schedule you. And then after your evaluation, we kind of talk to you about this is how many times a week we'd like to see you. Generally, it's twice a week. Sometimes it's only once a week, depending on your schedule and what we might feel you need. So it's a little bit of a conversation sometimes. If, you don't live close by and coming twice a week is really difficult, then we'll go once a week. It just kind of depends on what we see as what deficits are there. And, it's our kind of objective look and decision making of what we feel like, how often you need to kind of be here with us. And then I think there was a question, was it about pain or payment? I might have misheard the end of that question.
Let's do both.
Okay. Generally, it's not very painful. I mean, you might have some discomfort. I'm not gonna lie. Like if we're working on some range of motion, I always tell patients, and all my therapists tell patients, when you're having tightness, let's say, or you're having some decreased range of motion, we want to start stretching you a little bit gently into those ranges where you're not able to go. So it may be a little uncomfortable, but you never want to be in pain. Like that is never. Through any of this, I would say through all physical therapy, especially when you're talking cancer treatment and, you should not be in pain. If you're having pain, we need to reassess what we're doing. We need to maybe back off. We need to adapt what we're doing as a physical therapist because we don't want you to be in pain. When it comes to payment, most every insurance pays for physical therapy. And so, we'll do our evaluation. If we have to request visits, that's what our administrators up front, Lisa and Kidis, Lisa's amazing. She's the one who does most of the insurance, but she'll say, the patient has 12 visits. If we get close, then I usually reevaluate you. We may need to ask for more, but generally, visits are covered and they're paid for depending on what your insurance plan is. And if you're not in network, she would let you know that ahead of time before you came in for your evaluation. But there's not many, I think, plans that we have in Maryland that we do not participate with. And even those that we don't, I know sometimes we've had times where like Blue Choice, I believe, is not, at least it wasn't at one point. I could be wrong, but I may misspeak here, but Blue Choice, I know at one point was not covering, you couldn't come for regular physical therapy, but you could come for lymphedema treatment. They would give that exemption because it's not something that's easy to find always in network. So sometimes there's a little bit of some give and take on that end, but it's something that they would let you know up front when you call and tell us what your insurance is. She would be able to tell you whether or not you're covered or not covered, and that would depend again on what your plan does for physical therapy. There should be somewhere in your plan it'll tell you what your coverage would be.
Got it. Thank you. And actually, a question came in from Marjorie. It says, how do I manage lymphedema in the breast? I had lymphedema in my legs after colon cancer, and my husband learned lymphatic drainage massage. But how can I work with this in my breast?
So is you still do manual lymphatic drainage, but it's done obviously a little differently because you're directing the fluid from the breast. You want to really open up your cervical lymph nodes, and then generally the lymph nodes on the other side from where the swelling is. And you would move the fluid over that way. I would probably recommend there are YouTube videos you can probably find online. I know there's a lot out there, but if you've never been treated or talked about the breast lymphedema, I probably would recommend you come in for a consult. At least there's also like bras and special things out there we can do that help with that as well. So it's probably worth a conversation and at least a visit or two, even if you don't feel like you need a lot long term because you're pretty familiar with lymphedema and you've worked, you've dealt with it with your lower extremities. I still think it would be worth it to come in and talk about it as far as like what does the breast look like? Let us take a look at it. Recommend, make sure you understand the pathways we should use for the manual lymphatic drainage because it's a little bit different too for someone who says just has breast lymphedema. And then somebody who has breast lymphedema, but also has had lower extremity lymphedema, because we don't want to be moving fluid now from the breast down into the groin, which would be a normal way we would do this kind of massage. You want to make sure we stay away from the groin area too, because obviously you have some compromise down in the legs.
Well, thank you. I will do that.
Christine, here's someone. Another question, Lindsay.
This is from Dottie. I experienced lipedema and my condition has improved after PT, but I have not restored strength to pre-surgical state. Is that to be expected?
I would say yes. More than likely, if if the lymphedema is improved, but maybe you worked more on the lymphedema than say on some strengthening or some exercises to really help build your strength back, and a lot of patients don't really know what to do or how to start that, then I would say you probably don't have your full strength, and that's when maybe you come back and don't really focus so much on lymphedema, but on learning maybe what to do to help start off with how to progress your strength, how to do some lightweight training, how do we progress with that. I think would be probably something we do need to do, because if you're not using those muscles, they're going to stay weak, right? Like anything, you don't move it, we kind of lose it. So, and unfortunately, if we don't move, we lose it faster than we gain it back. So it takes time to kind of build that strength back up, especially depending on our age and where we are in our aging spectrum. As we get older, it takes a little more time. When we're younger, we tend to build it back a little bit quicker. So I think, maybe shifting that focus, if the lymphedema is doing well, how do we start strengthening for you and still keep an eye on the lymphedema, but be able to start building back that strength?
Questions? Christine, I had a question also about the peripheral neuropathy. You talked about how there's certain things that can help that a little bit. Do you do any of the electrosensory work with peripheral neuropathy? I don't know if it would be a TENS where there's, electrical stimulation or just that slow energy to help. Is that something that you've seen out there or that you
I have seen it out there. I've heard about it, but we have not done it in clinic yet, to be honest. I'd honestly have to look into that a little more. I don't know if our electric stim machines, if the frequency is set for the same frequency they're using with it to do the peripheral neuropathy. I'd have to kind of look into that a little bit closer. We have not used our e-stim machines to trial that yet with the peripheral neuropathy, which is very interesting though. So maybe I'll myself or get one of my other coworkers to look into that a little bit on that. And I don't know, I would be curious to see what wavelengths and what frequencies they're using for it and see if we can adapt it then to what we have in clinic.
Okay. What do you mean what you have in clinic? You have something like that in clinic?
So we have electrical stim machines in clinic that we use
right.
for our orthopedic patients, I would honestly say, or sometimes also some stroke patients, depending what you're using it for. But most of the time, the e-stim machines we have in clinic, we're using for reduction of pain, reduction of inflammation. They're kind of like preset parameters that are already on there for the most part. And then sometimes we use them though for like muscle strengthening, like quad strengthening, like functional electrical stimulation for patients, say like after knee rehab, we use it after total knees, and sometimes with stroke rehab to be able to get more muscle tone, that kind of thing back. So I'm curious if the machines out there for peripheral neuropathy are using which frequency and wavelength, are they the same as the ones we, could we adapt it a little bit for what we already have? That I don't know.
I see. Okay. But I have read a lot about balance with peripheral neuropathy, that there's a numbness and tingling, so your balance might be off. So that's something that physical therapy does
Yes.
work with.
Yes, we do that quite a bit. Even we see it with patients, obviously with coming from cancer quite a bit because of their chemotherapy, especially if you've had some of the taxane Taxol therapy. Chemotherapy tends to be one of the ones that really sets in the peripheral neuropathy, but we do it a lot with other patients who have peripheral neuropathy from other reasons too. And it really, you can make huge gains in balance, even though you have some of that limited feel and tingling and numbness. We do see some great gains in patients being more stable on their feet, increasing their balance, their walking gets better. So it's been good. We've seen some great results with patients.
Well, that's wonderful. And that's what I was going to say. If we can look out for balance issues so that there isn't a fall, which then creates a trajectory of you can't have the walking exercise that you need, or if you feel unsure being out there walking, then if we can improve the balance, then you can feel better that way and safer that way, then when you can exercise more, which we know that exercise can help with peripheral neuropathy and staying active. So so it's good to think about it that way, even if you feel like you're a little off balance, but not too bad, and you don't think you're ever going to have a fall. Well, making sure that all that is okay. And that's a benefit of physical therapy, is checking all that out and getting a good, regimen and eyes on you to make sure that you're getting and moving along as well as you possibly can.
Yeah, absolutely. I could not agree more. I think, even if you notice general activities you do in your everyday, it's a little harder for you to get out of bed. It's a little harder to get out of your favorite chair. Like even things like that are kind of earlier red flags of things that you're getting a little weaker. And, that then leads to weakness, kind of then starts to lead into more of that higher risk of falls and balance. And as Ginny says, we want to see you before you have a fall, because that's what we're hoping to prevent in the first place, is that you don't get to that point where you've now fallen and God forbid broke something or something awful like that. But even if you have a fall, that's not good either. Even if you luckily nothing bad happened. So, seeing patients and getting to you early and being able to say, hey, look, you're still doing really well, but let's get a program in place that's going to keep you where we want you to be, and not have that, it tends to be a pretty slow decline a lot of times when it comes on. It doesn't happen overnight. And sometimes you're not even really aware as a patient that, maybe this is happening. You have so much on your plate to start with. You're running to this appointment and that appointment. And, so I 100% agree. Anything that you notice kind of in your everyday that's becoming a little more difficult, a little bit harder to do, maybe a flag that makes you think, I wonder if it would benefit me to go see physical therapy. I mean, if you look great for us, we might give you a couple exercises. We might just send you on your way and say, no, you look fantastic. But, it doesn't hurt to always come in and maybe have that little check, we do different balance tests with you. We do what we call usually a get up and go. We make you get up and walk around a cone and come back in a certain number of seconds. And it seems silly, but they are real good indicators of kind of how are you moving? How is your balance doing? So definitely better to be seen early than later. And that way we can, intervene before you lose more strength, or before that balance becomes so much to a point that we, risk you falling.
That's great. That's great. And I guess Lindsay asked this, but once again, relating to insurance or getting a referral, how far out from cancer can you be and still say this is cancer-related fatigue, or this is, residual peripheral neuropathy? Can that be challenging, and what can patients do for that?
We have not had a problem with it up to this point. I really think, honestly, thankfully, I think most insurance companies realize that just because you've stopped your active treatment, let's say you're done with your chemotherapy, you're done with radiation, those effects go on for pretty much a lifetime to some degree. They go on for definitely for years. We have not had an insurance deny or not pay, as far as I've known, for having someone who, say, is even like 5 years out and still struggling with peripheral neuropathy, or struggling with, being deconditioned. And in general, you can come to physical therapy just for deconditioning. So we might know what's coming from your cancer treatment possibly, but we can still put your diagnosis code on our PTN as just being deconditioned or having impaired balance, and that still gets covered under physical therapy benefits, regardless of maybe what the underlying cause of that might be. So, it doesn't necessarily have to, they don't have to prove that it's coming from your cancer. just having those kind of deficits and presenting with them anyways is enough to justify having physical therapy.
Great, okay. And then I was wondering when you talked about some of the gynecological or urinary, is there pelvic floor rehab that you have?
So we do not do pelvic floor rehab at this time. I have heard they are looking for someone to start and do that, but it is not here yet. So, on our end of what we do right now in the clinic, it is more on, dealing with lymphedema issues, let's say, that are in the lower extremity, a little bit of pelvic. If it's true genital, some of that we refer out to downtown, it depends. But more so if you're talking more like the pelvic floor end, I believe there's a few therapists in the area that do it, but we unfortunately don't do it here yet. But I do believe it is coming, hopefully. I just don't know when it's coming. So
Great. Thanks for letting us know that.
It's a great question though, because yes, even those not in this end usually can benefit from that sometimes. So I know it's something they've been definitely talking about, but yes, for sure. I know that's a problem for a lot of patients.
And what does the physical therapy look like for cancer fatigue? Like, what do you do when you see them? Do you run out of the building? Do you?
So for cancer fatigue, and again, I think some of this goes along with, how often we see you. It is a lot of times with cancer fatigue, you will find that patients are also very deconditioned. So you've got a lot of I call more truncal hip weakness a lot of times. So some core, but a lot in your hip abductors, your hip flexors, which your lower extremities. So a lot of it is starting, giving you a home exercise program to do some of those exercises more at home. And then in clinic, we tend to focus, once we know you're comfortable with those exercises, we tend to focus a little bit more on, if you need balance work, we work on balance. We have, multiple machines in the clinic. We have, a new step, bikes, different things to just start getting your cardio up while monitoring you, obviously heart rate, blood pressure, how you're feeling on that end. We also balance whether you come twice a week or once a week, depending if you're still maybe in therapy and how you feel. It can be a little bit of a fine balance. We don't want to overtax you, but we want to make sure we are making slow progress and that you're still doing things daily, because they've really found that a lot of times cancer fatigue, some of the best thing to do is really to sometimes push through a little bit and at least do some sort of activity every single day, even though I know that you don't want to, but because you don't feel good. But that has actually been proven in many studies long term to actually prove to have less cancer fatigue than in the long run. So, it varies patient to patient, obviously, but a lot of it is, and I think on an OT end a little bit, I'll jump to them. They work a little bit more on energy conservation, and they'll get into that, I think, a little bit more on Friday. But, it can be a balance sometimes between maybe seeing both of us or one of us seeing you, but we can kind of tag team a little bit on that end too. So I hope that answers some of the question with the fatigue, because it is about strengthening, working on getting that gait, but getting you more comfortable on your feet and slowly starting to build that endurance really back to getting you back where you want to be.
And I see a question that is about cancer fatigue versus post-anesthesia fatigue. And I think, Christina, you can help me with this, but I think it might be that the post-anesthesia should be short-term. That should wear away when your body has metabolized and processed any of that chemical anesthesia. And a cancer fatigue is something that would last longer.
Yes, I would agree. Usually your post-anesthesia fatigue should be pretty short acting. It depends on how long your surgery is or how long you're under, but I would say generally and I think 48 hours, and Jenny, you might know more about this than me personally, I think it's generally out of your system, I think. Now, I do know post-anesthesia on a cognitive end can have longer lasting effects, but on a true muscle fatigue end, I believe within about 48 hours, it's usually out of your system. Whereas for sure, I know with, the radiation, the chemotherapy, even they say at least 6 months sometimes, if not longer, it can take for that really truly work its way out of its system. And then depending on how you've been able to be active through that time, that deconditioning has set in. It can take you much longer than to recover from that, because it's not just always the chemicals that are in there. It's also what has your body been doing now over those months too at the same time. So it's a little bit of a dual action going on there.
Yeah, absolutely. And I mean, there may not be a hard 48 hours because it could be that it's not really the fatigue that's related to the anesthesia, but the stress of having to have that surgery and the preparation for all that, same as what is cancer fatigue. It's the body, but it's also just the impact of all the stress that you've been through, chemically, physically, emotionally, that can make this fatigue daunting and a little longer lasting than you'd want to. And that's why they talk about exercising being such an amazing thing for it, because you get chemical releases, you know, the dopamine response and things and endorphins that help you feel a little bit better. And then also you're moving your body. So you're, you know, processing, metabolizing, excreting. So that's why the exercise can be so helpful. But I would think that maybe someone hearing post-anesthesia fatigue or being told about it, it could get confusing. And is it literally just the chemicals, or is it the other parts that can fall into it, such as, again, the stress of having to have a surgery? So either way, if the fatigue's lasting and it's not comfortable and it's impacting you, let's get you seen by physical therapy.
Yeah, I mean, we luckily get to spend a lot of time with our patients. So, you know, we talk about stress all the time when I'm with my patients, no matter if that's not maybe the real reason why you're physically seeing me for physical therapy. You know, as you know, Ginny stated so perfectly, like, you know, it is extremely stressful to be diagnosed with cancer and to go through all of the treatment and then even beyond as you're juggling your life and your children and everything else that you have to do every day, and even the stress of the diagnosis itself. So, you know, sometimes coming and getting your mind a little bit off or talking about the things that are on your mind even when you're with us can be sometimes a little bit, you know, anxiety and stress relieving in and of itself too, let alone all the other great stuff we have across the hall with Jenny and her wellness center that do amazing work for us with our patients on that end too. But I found a lot of patients, I think, also just feel comfortable coming and, you know, you get 45, 60 minutes one-on-one with your therapist who not only are working on you, obviously, to get you physically back to where we want you to be, but sometimes just having and being able to share things that you can't tell your spouse or your, you know, you can't feel like you can't share with other people because they may not understand, you know, you got our undivided attention for 45 minutes to 60 minutes. So, you know, sometimes that can be really helpful too in many ways.
Absolutely. And taking an active role in moving forward, right? It's an opportunity for you to empower yourselves and to be that main provider of your care team. So yeah, that's very exciting. Any other questions or things that we didn't cover? Because it's just so wonderful, Christine. Thank you for all this information about physical therapy and the resources. But yeah,
You're
any
very
other
welcome.
things?
I hope, you know, there's those out there, maybe you're feel like, oh gosh, I didn't know you know, physical therapy could do that, or I could still go to physical therapy, you know, even though it's been maybe a year or so since you finished treatment, or, you know, didn't realize that maybe all the stuff we had to offer here, but we'd love to see you and, you know, be able to help you guys in any way possible. So thank you for having me.
Yeah. Any other comments or any other experiences with PT that you all have or questions about? Lindsay, how about you? Is there anything that you're seeing with patients asking questions? That was a great point that you made earlier and asked us.
Um, no, a lot of them are just, they always ask like, oh, is there anyone that can treat my lymphedema? And I'm like, yes, they're right across the hall. So, I think that might just be a thing that we have to really vocalize to tell everybody that you don't have to like always, that we have that service available, and that, yeah, we're happy to treat you and happy to make, you feel better in any way that we possibly can. So I think my question before and that are my two biggest, things that I encounter with patients.
Good, good. Thank you. And that reminded me that a lot of people ask after they're done working with Christine or with physical therapy for lymphedema, is about a lymphedema massage therapist. And we had one here, and we hope to start that up again. That's certainly all changed because of the pandemic. But we're talking with massage therapists now, and hope that maybe by August, September, we'll have someone that's here and can start offering that transition from working with physical therapy with Christine, that in between, before you're, in between your checkups, to be able to have some of that lymphedema massage if that's what you're looking for. So we'll be here for you.
Yeah, that would be a great transition, because I have patients too that want even to go get massages, are always looking for a good massage therapist, but also like them to have at least a knowledge of what lymphedema is too, to make them feel more comfortable getting the massage done then too, for even other issues. So that would be great.
All right, everybody. Well, thank you. And
Thank you.
keep tuning in. It's great. Happy Survivorship Week. Thank you. Thank you very much, Christine.
Thank you guys so much for having me.
All right. Bye-bye.